Welcome to the next episode of On Call with Dr. Jason Golbin. I have an incredible guest who I've known her whole time here at Catholic Health, Dr. Jana Deitch, who has two great titles. First of all, she runs breast health at St. Catherine of Siena Hospital in Smithtown. But more importantly, she is the chief of breast surgery for Catholic Health. Welcome to the show.
Thank you so much.
Oh, we're so happy to have you. We were chuckling here before you got, when we were chit-chatting beforehand. We chit-chat beforehand. And I take the credit for hiring you. I still remember the interview. You came in and we said, oh, my God, grab her, whatever it takes.
Yes.
And you've been an amazing success.
Thank you.
For Catholic Health. We're really, really blessed to have you.
Thank you so much. Yeah, I remember that too.
Right. Right. Okay.
Yeah, I remember it.
Where'd you get your start? Where'd you grow up? Where'd you go to college? Where'd you go to medical school? How'd you get to be the chief of breast surgery?
Yeah, so I grew up here on Long Island, and I always knew I wanted to come back here. So I did leave and went to University of Maryland, College Park for college.
You enjoyed that?
And I loved it.
Yeah.
Great school, great education, a lot of fun, great sports.
You were pre-med right from the start?
So I was pre-med right from the start. They didn't have like pre-med, but essentially.
What was your major? Biology?
Neurobiology and physiology. It's a mouthful. But it was all the pre-med, prereqs. And then I went to St. George's University School of Medicine in Grenada.
Well, that must have been an experience, right?
That was an amazing experience. I was hesitant to go to start. It was a big change. It was out of a comfort zone, and I did not know anyone going. But it really was a remarkable experience. I grew up. I became independent. I had an amazing education.
Did you study on the beach?
We used to a little bit study on the beach.
Right?
We really would just go after finals to the beach and party. But
right, because you had to study.
You had to study. You had to study.
Beautiful location, but you didn't really even get to enjoy it.
Right. I mean, the library was looking out over the ocean, so when you looked
out the window, right? That's
exactly,
it.
Exactly. But an amazing education, and I got into an amazing general surgery residency program at Maimonides Medical Center in Brooklyn.
Okay, wait. Why general surgery? So I remember going to med school, and I got to surgery. I said, oh my, I thought I wanted to be a surgeon.
Right.
Until I got to the OR, I said, this is not for me.
Yes.
You must have had the opposite reaction.
I did. I thought I wanted to go into surgery. When you're in medical school,
you don't really know.
You don't really know, especially like the first 2 years. You're just like in the classroom, you're learning. The third year, right, you're doing all your core rotations. And surgery was my last core rotation. So I went through every subspecialty. I went through medicine, gynecology, pediatrics, everything. Right. And every rotation, I said, this is going to be it. I'm going to want to do this.
Oh, so you liked each thing as you went through it.
But then when it would end, I'd say, no, not for me.
Okay.
And then
that's probably the right attitude, right? For the buddy med students out there.
And I didn't really want to do surgery. I thought, I loved it. Internally, I wanted it. But logically, I was like,
it's a tough life.
It's a tough life. Right. It's a tough residency. It's a tough life. It's very hard. It's the longest residency program. And then I got to surgery, my rotation, and it didn't matter that I was up at 5 a.m. and home at 9 o'clock at night. I was motivated, I was energized, and I loved it. And
that's it. That's how you know, yes. Right? I mean, okay, all right.
Yes.
So you say I'm going to do surgery. You go to MIMO in Brooklyn.
MIMO in Brooklyn.
Great hospital, great
amazing.
program.
I mean the
pathology,
the diversity,
right.
The pathology, the acuity. We had the most amazing education there, experiences. I still talk about it. I miss it, but it really prepared me.
So you do 5 years of general, just so everybody knows.
5 years of general surgery. I actually did 1 year of research between my second year and my third year.
In breast?
In breast.
So that's when did you start knowing about breast surgery?
So I started when I did my sub-I as a fourth year medical student at Maimonides.
At Maimonides, okay.
Yes, and the chairman of surgery at Maimonides is a breast surgeon, Dr. Pat Borgen, who's a giant in breast surgery, and I was so motivated by him and his patients and his compassion with his patients and all the surgeries, and I really started my residency program knowing that I wanted to go into breast, but I did spend 5 years of doing general surgery to get there.
That's right. That's the cost of doing business, right?
Yes, exactly.
I just want to pause on that for a second. I think it's really interesting. The people that you meet serendipitously, right? Who knew that you would do your sub-I at MIMO, and there's this, maybe if it was a vascular, it would have been a vascular.
Right.
I tell a story that after I went through, I wanted to be an orthopedic surgeon and then didn't like surgery. Then I wanted to be a dermatologist and then realized I didn't want to do that. And then I said, I'm going to be an interventional cardiologist to save lives. And then I remember you'll appreciate this as a medical intern, my first month, patient starts getting real sick on the floor. And my senior resident, who's now a local GI doctor, said, I got this taken care of. And he makes one call, and onto the floor comes this incredible pulmonary critical care doc with, cool hair, and he's wearing a Hermes scarf, not like your typical.
Yeah.
And he goes in and he intubates the patient. He puts it on all by himself, and he personally wheels the patient to the ICU. And then 3 days later, he wheels the patient back. Patient's sitting up, looking good. He's still looking cool, That's the kind of doctor I want to be. It's these, and that's it. It changes your life.
Yes, it does. It does. And it just puts you on the path that you may have not been on had you been in a different place at a different time.
All right. So you did your 5, you did your research, and then where'd you do breast?
I did my breast fellowship at St. Luke's Roosevelt, Beth Israel, Mount Sinai.
The continuum.
The
old continuum.
Yeah, the old continuum.
Yeah.
And that's 1 year. And at that point, one of my attendings knew a breast surgeon who worked at St. Cat's, introduced me, and the rest is history.
Isn't that amazing?
Yes.
Amazing. All right, but now you're not just at St. Catherine's. You've expanded for the system. Talk about that a little.
Yeah, so very exciting. I've been actually at St. Catherine's for 10 years. So a year ago, about 9 years in.
10 years. Huh?
10 years.
Wow, we're getting old.
We're getting old,
Oh, my
yes.
God, okay.
Yes, so about a year ago, I expanded my role to be system chief for breast, which allows me to kind of oversee all the breast programs because we do breast surgery at several of our system hospitals and make it more of a uniform program, a division of Catholic Health versus, breast surgery at St. Catherine's, breast surgery at St. Francis, and making sure our standards are met and our compliance is good and our outcomes obviously are our most important metric, but making sure everything runs very smoothly. And I now also do see patients and operate at St. Francis as well.
All right, so let's talk about systemness. So we're on the journey as a health system, right, towards systemness. We were, if you go back 20 years, 6 hospitals, under the umbrella, but we are really now Catholic Health.
Yes.
While each hospital has its own unique personality and culture, I think we're driving in every specialty, in every aspect towards the systemness. Has it been challenging? Is it hard to get the campuses to mold in that direction, or are people excited? Are your breast surgeons, I don't know how many breast surgeons we have, probably a nice handful across the organization.
Yeah.
I can only imagine that they're excited to continue to rigorously transform.
Yes, so everyone's excited. It is definitely difficult because there are habits and each hospital, each department, each system has their way of doing things.
And it's not just the breast surgery, it's in everything.
Right, and for breast, it's not just the breast surgeons, it's the breast radiologists, the medical oncologists, the radiation. It's a very multidisciplinary program, so to say. And to try to make change is difficult.
Change is hard, always, yeah.
And, one hospital might think their way is the right way, and another one might think their way is the right way. So it does take time, a lot of talking, a lot of, patience to get there. But I think everyone's excited about it. We do system-wide tumor boards where we present
for the whole system.
For the whole system,
that's really cool. So you have everybody in the room.
100 people are on the tumor board.
Medical oncology, breast surgery,
radiation oncology, pathology,
and
plastics.
Right, that's right. And imaging too, right? Because the radiologists are just as important, especially talk about breast imaging. I mean, it's its own specialty. They are, at least my understanding, amazing partners to the breast surgeon.
Yes.
Talk about that relationship a little.
Yeah, you have to have a great relationship between the breast surgeon and the breast radiologist because I'm only as good as my radiologist. I can't operate if I don't have the radiologist localizing the lesions for me. I can't diagnose a patient with early breast cancer if my radiologist is missing it. So if a team, the ideal team is an excellent breast radiologist and excellent breast surgeon. The amount of times that you have to speak to them and work with them so intimately really is like key to success.
We have some amazing ones.
We have amazing breast radiologists. We have multiple sites, and they all are breast dedicated. So you're getting like top-notch care.
What surprised me my first interaction as my wife had breast cancer, but I didn't know radiologists actually talk to patients.
Yes.
Now I say that a little bit in jest, but not really.
Yes.
Right? So for when a patient comes through to get their screening mammographies, the radiologist comes out, talks to the patients, not sitting in the back office, and that's rare. I don't think it's completely unique, but unless think of intervention radiology, others, but in general, the radiologist is behind the scene. You get the report; it shows up on your phone. You read the report.
You're right.
What a different. And so it self-selects for a certain kind of radiologist.
Yes, it's definitely, you said not unique, but it actually is unique. You go to some community radiology facilities, and it's a true screening program, meaning you walk in, you get your 4 mammographies, 2 on each breast, maybe you get a sonogram by a technologist, and then you leave, and then you may have to come back in and do more imaging and more, and biopsies, and you get the report from your portal or from your referring doctor.
Right, now it shows up on your phone immediately. Right,
Our radiologists, everything, even though you're going in for screening, it's almost run as a diagnostic program where they are looking at it in real time. They are coming out and telling you, hey, I see this cluster of calcifications. I want to magnify them. Give us 5 minutes. We'll get you back in the machine. Or, it turns out that area is suspicious. Let's schedule you for a biopsy. You leave knowing your results. You're not waiting, on pins and needles to know, like, am I okay? And sometimes that could take a week
without
to find
the personal touch.
Exactly.
And then I'm sure if they do find something, then it's a personal phone call to you.
Yes.
Or to one of our breast surgeons to say.
Exactly.
And then it's a warm handoff, right? So it's a conversation. That's priceless. I as a male, I do a prostate screen. It's different, right? It's I went and did my MRI, and then I waited for the result in the portal. And I called my urologist, who's my friend. I said, "Did you see it?" So it's different. But I appreciate that. Let's talk about the field of breast surgery in general. I mean, cancer surgery is just evolving, exploding. We've had some amazing robotic, general cancer surgeons on here. But tell me what breast surgery looks like in 2026 and beyond.
Yeah. So breast surgery has completely evolved. I mean, from like the inception of mastectomy, in the 1850s, 1900s, it's like night and day. Really, it's remarkable. But even over the last, say, 10 years that I've been in practice, it's changed. I mean, surgeries are getting smaller. Mastectomies and reconstructions are getting better, where sometimes I say to patients, if I didn't do your mastectomy myself,
you wouldn't know?
I would not even know you had a mastectomy.
Wow. But is that a comment on the plastic surgeon or the breast surgeon? Probably both, right?
Both, because if you ask a plastic surgeon, their rate limiting, for success is how the mastectomy is done.
That's so interesting. Okay,
so.
I don't think I ever put those together.
Yeah, so if you have a bad mastectomy, you're not going to have a good reconstruction. Right. And yes, you have to have good reconstructive surgeons, and luckily, I have. We have some great ones around here. So, but our lumpectomies, our partial mastectomies, I mean, we're hiding our incisions. You can't even see where we did the surgery. We're doing like oncoplastic closure where there's no deformity to the shape of the breast, even after a large lumpectomy. I mean, we're really evolving because we want sort of the memory of the surgery to be gone. And yes, the diagnosis remains with the patient forever. We're not asking them to forget they ever had breast cancer, but we don't need a physical reminder every day.
Is the evidence changing where instead of a mastectomy, we could do a lump? Has the evidence been proven that it's just as safe or equally efficient?
Yes. There's breast conserving therapy, which is lumpectomy plus radiation, is for most breast cancers, nearly or essentially equivalent to a mastectomy in terms of recurrence, breast cancer recurrence in the breast, and overall survival. So, I say to patients, you're not going to do better because you've had a bigger operation.
That's interesting, right?
Yes,
And that's
and
opposite what you think as a surgeon, right? A
Exactly.
surgeon,
Yeah,
cut, right?
Exactly. But the radiation really accomplishes that like extra help that the mastectomy is giving the patient. So if you don't have radiation, yes, there are differences in the outcomes, but radiation is part of our standard treatment for breast conservation. So women do equally as well.
And I'm assuming it's the same thing. It's a warm handoff with you with the radiologist, but I'm more thinking about your tumor board.
Yeah.
So let's say you see somebody with a big tumor burden, a lot of disease. You bring it to tumor burden, and then the board sits, and the radonc says, maybe I can shrink it first before.
Yeah.
So talk about those conversations. What are those like?
So,
Is it just conversation like that?
Yes, exactly. So actually, we had a tumor board this morning before I came here.
Hey, surgeons, early morning, right?
Early morning
Yeah.
starts, right.
It's still early here.
Yes. So sometimes patients come in, yes, with large tumor burdens, or the breast cancer had already spread into their lymph nodes in their axilla.
Right.
And upfront surgery might not be best for them. So we sometimes recommend that they have neoadjuvant, meaning prior to surgery treatment. And that could be chemotherapy, that can be immunotherapy,
Right,
hormone
immunotherapy is
therapy.
changing the game too, right?
Exactly, where we can shrink the tumor, kill off any disease potentially in the armpit, right, in those lymph nodes, and a patient might be able to have a smaller operation. And sometimes that does provide survival benefit.
Oh, that's amazing.
Yes.
I think that the fact that we're doing that as a system is
Yes.
is reassuring.
Yes, and it shouldn't just be my decision, right? I see a patient, I shouldn't be the only person deciding their course of action. So we presented, and it's multiple surgeons, multiple oncologists, and sometimes we don't come to a full agreement because there's no right or wrong answer. You can do it this way, or you could do it this way.
And then you present it
And
to
we
the
present it
patient.
to the patient, exactly.
So they can have an informed decision.
Exactly,
I love that.
informed decision, exactly.
I love that. What do you see as outcomes of your breast surgery patients now? My wife was sick, and to this day we think only the fondest of our breast surgeon. But we saw her for a couple of years, and then we stopped seeing her. Now she had a mastectomy, so but even still, we kept saying we want to come back. We want to come back because we built such a bond, and it was such a emotional thing. Tell me about the bond with your patients, and especially as a woman.
Yeah, it's that was actually one of the reasons. It's not just I like the physical surgery of breast surgery. I like the relationship that the breast surgeon has with their patients, and it's not just with the patient themselves; it's with the family.
Oh.
And actually, breast surgery, I used to describe it as like a generational practice. I sometimes see a
kids,
mother and then the daughter,
That's right.
and then I see the children. Like I'll see multiple generations in one family, and the trust that these women, sometimes men, I see men as well,
That's right.
put into
1% of
put
breast
on
cancer
me.
is male, right?
It's humbling. I don't take for granted that they're putting their life in my hands. And yes, I'm not performing surgery on their heart. Like it's not a imminent, life in my hands, or literally, but
it still.
it still is, and they're trusting me to make the right decisions for them. They don't know. They're trusting my guidance, and it does not go, unappreciated at all. I really, I'm honored when patients choose me to be their surgeon. They have a ton of options on Long Island. We're only how many miles away from New York City?
Right.
I mean, it's not like we live in rural, middle of the country where there's no one for another, 300 miles. So it really is an honor to me when patients allow me to be part of their care.
I'd say that shines off in your general demeanor, the way you treat patients. But I see it also in your team. I've known your team around you. How do you get the whole team to have that same kind of compassion and passion, and caring for the patient?
Yeah, well, I think you surround yourself typically with people who you like, and to people who are similar to you will like emanate the same feelings. And it goes from everyone in my office, my MAs, to my nurse, to my surgical coordinator, out to the radiologist and their staff, and to the medical oncologists that I work with. And so I send people to physicians that I personally like, because if they have a nice personality, the patients will like them also, but also obviously who are also very good
High
at
quality,
what they
right?
do.
Of course. That's the best
Yes.
standard. All right, so let's talk about you a little, because we've been talking a lot about breast surgery. I mean, it's a stressful job, right? It is somebody's life in your hand, especially we're dealing with once you hear the word cancer, you hear nothing else.
Nothing else.
Nothing. What do you do to relax? What's your downtime look? What does your family life look like? Give me a flavor.
Yeah. So, I work full time, so I work a lot. And then I go home to my second job, which is being a mom.
How many kids?
I have two boys, 9 and almost 11.
Yeah.
So our afternoons are very busy. We play lots of sports. We have lots of activities.
What do they play?
They play soccer and basketball and tennis and golf, and I run from work to the fields.
Yeah.
Usually I'm meeting them at whatever game they're at, with my scrubs on or whatever it may be, and and then we the evening time, that's when we're all together, doing homework, watching TV, trying to relax. And it's nice to be able to go from a stressful job to your home life, which I'm not saying isn't stressful. Please, running to the fields and the merry-go-round of carpools is stressful. But if you can go home and see joy in your life at home, it makes the balance well worth it.
I love that. And golf. Let's talk about golf. I know you golf a little. Talk about golf.
Yeah. So I grew up in a golfing family. My parents golf. My husband, ironically, I married somebody who's a very good golfer.
Do you think that was like, would you, if he wasn't a golfer, you think you still would have married him?
Yeah, I think so, because I think
it wasn't the golf.
It wasn't the golf.
Okay.
Actually, his first thing that he ever, said to me is he's like a fisherman. He likes to go fishing.
Oh, really?
Yes. My husband has lots of hobbies.
Good.
Which makes it difficult for me to have lots of hobbies.
That's interesting.
Yeah, so he's a big golfer. We belong to a golf course, and my kids love it.
That's amazing.
They love golfing. They played on our teams junior PGA
already. Wow.
Yep, and they're very good golfers.
Yeah. You learned that skill as a kid.
I might be the worst golfer in my family.
Isn't that amazing?
Yes.
And you grew up playing it.
And I grew up playing. Yes, but of course I don't have too much time to golf.
No.
So
of course.
they play more golf. They take more lessons because it's me or them taking the lesson on a Saturday afternoon, so it's going to be them.
Yeah. Oh, I love that.
But we love playing together. We go out awesome. 9 holes. They beg
Four
for
of
18.
you. That is so cool.
Yeah. They beg to play 18.
Yeah,
I compromise on 9.
Yeah. That's I grew up on Staten Island.
Yeah.
We didn't play golf. I don't even know what golf was. Yeah. We played baseball and football.
Yes.
But now for my little 6-year-old, I've taken him to the driving range, and I say, we're going to get you on the course this year. I'll show you a video. He's hitting it 50 yards.
Yeah.
It's amazing. If you learn that it's like a baseball. I could pick up a baseball bat tomorrow and swing like I did when I was 15.
Yes.
Right.
Sure they say riding a bike.
That's right. It's a gift you're giving them, because the golf you could play.
Forever.
My grandpa was playing until his 80s. It's all right. Here's my last question. We always end with, as you see the young generation. Well, St. Catherine's now has surgical residents. I mean, right? Things are changing. Mm-hmm. So when you, which I'm sure you love. I just see your person. I can only imagine how great it would be to scrub with you.
Yeah.
But as you see, either the generation of college kids becoming medical students becoming, what one piece of advice would you share with them from your amazing career so far?
Yeah, I think it's just, even if it's hard, even if you feel discouraged, don't stop. My journey from, being in college through residency, through my, career now, was not what I thought maybe exactly the path would be. There were hiccups, there were difficult times, but I had a passion, and I didn't let something stop me from pursuing it. So, if you really have a passion, you love something, do it. However it is, you'll get there, it might not be the way you thought, but you'll get there.
I love it. That's a great piece of advice. You really have to have that stick-to-itiveness. I don't know if that's a word to get where to get to the at least on the journey.
Yes, exactly. Don't let someone discourage you.
I love that. That's great. Well, listen, it's been amazing. We are so happy and pleased and lucky to have you as Chief of Breast Surgery for the health system, as well as your role at St. Catherine of Siena. And I am super pleased to call you both a friend and a doctor.
Thank you.
So thank you so much for everything. It's amazing to have you here.
Thanks for having me.
It's a pleasure.